Chapter 17 is blood, and what we see here is a really fantastic picture of a microscope image of blood, and we see the erythrocytes, or the red blood cells. The leukocytes are the white blood cells, and then we see a lot of platelets. And platelets, as we'll discover in a little bit, have to do with clotting blood so that you will stop bleeding should you experience that. So several different pieces here in what we would consider the formed elements, the blood cells. So this is the stuff outside of plasma and outside of the dissolved protein that you would have read about in the first page or so of your reading assignment. If we look at an image of blood that we would see under our microscopes, the previous picture was a microscope view that we'll never see in person because that's a $250,000 microscope. But what our scopes would give us is this image here. And we would see red blood cells, most of what you see in a blood smear. You would see a few pieces of platelet here and there, but our scopes aren't really great at picking that up. And then the other is white blood cells. And what you see is this particular image was a very carefully discovered image. They put a lot of effort into finding this one because it shows most of the white blood cells all in one image. Normally you wouldn't see that. But the important thing to note is that typically in a healthy person, you would see almost exclusively red blood cells and very few white blood cells. So only occasionally would you see a white blood cell in a healthy person. And that's indication that the immune system, in the form of the white blood cells, doesn't have anything that it's working against right now. This particular view may or may not have came from a healthy person, but certainly if these were all the same type of white blood cell, I would suggest that person definitely had a health problem. And in a little bit here, we'll learn what each of those types of white blood cells actually does, and then we would be able to diagnose to some degree what their problem was. Let's figure out these red blood cells right now, or these erythrocytes. The first order of business is that they are small. So if we go back to our previous image and look at that, that's a 600 times magnification. So that's better than our microscopes would do without using oil immersion. And then they've taken that particular magnification and stretched it out to a much larger enlarged image. So in reality, you could take tens of thousands of red blood cells and place them into the area occupied by one of these red blood cells in this image. So incredibly tiny. And if we look here, they're about 2.5 micrometers tall and a little over 7 micrometers wide. So those are really, really small increments. Notice their shape is round with a depression in the middle, sort of like a donut that didn't quite get the donut hole punched out. And they are this shape so that they can slide through capillaries. In a later chapter, we'll explore blood vessels, and we'll discover that capillaries are the smallest of the blood vessels. So these very, very tiny blood vessels, in some cases these red blood cells can only slide through them one cell at a time. So they're round so that they can squeeze through small openings. Really, what a red blood cell is an oxygen-carrying machine. So if we look at what actually is contained in that red blood cell, it's mostly water, but most of the solid non-water stuff in that cell is this molecule hemoglobin. And we should note about red blood cells is they don't repair themselves, which limits their lifespan to somewhere between 90 and 120 days, and then they must be replaced. And your bone marrow makes new red blood cells at the rate of about 100 million new ones a day. So that is probably about the rate that you would probably be losing those red blood cells. So every couple months, all of your red blood cells have been replaced. So inside here, this hemoglobin molecule is a very interesting shape, and what we want to note here is the presence of these red heme groups. So you'll note that there are 4 of these heme groups there. And if we pop it out here, we would see that it's this very complicated structure by itself. But importantly, we find an iron atom in the middle of it. And so you've heard about needing iron in your diet for red blood cells, and this is what it's really for, is the core ingredient of this protein, hemoglobin, and specifically the heme part of it. So if each heme group is capable of holding 1 molecule of oxygen, that means that a molecule of hemoglobin can carry 4 molecules of oxygen. So we're doing a little bit of math here. We're up to 4 molecules of oxygen per each hemoglobin molecule. There are approximately 250 million hemoglobin molecules in a single red blood cell. So this gives you some perspective of size. If 250 million of these guys can fit into a cell this size, this 7 micrometers across and 2 micrometers high, this is incredibly tiny stuff. So 250 million hemoglobins per red blood cell, 4 oxygens on each hemoglobin. Now we're up to about 1 billion molecules of oxygen that can be carried on a single red blood cell. Billion with a B. So that's an incredible number of oxygen molecules. And that's what it would take to satisfy just that one red blood cell. It's probably a conservative estimate to say that you might have 1 trillion or more red blood cells in circulation. So if we do the math on what 1 billion times 1 trillion is, it's a really, really, really big number. And that's how much oxygen it would take to saturate your blood with oxygen right now. But how long can you go in between breaths? So if you fill up all hemoglobins with oxygen now, how long can you go before you have to take another breath and start refilling them all over again? And the short answer to that is it's literally a matter of seconds before you need to start replacing that oxygen. So it's a tremendous amount of oxygen that you use. Even in the course of watching this video, you will consume trillions upon trillions upon trillions of oxygen molecules, doing nothing more than sitting and watching. Obviously, the more physically active you are, the higher rate of oxygen consumption that you would actually have. If we talk about someone being anemic, there are a number of different forms of anemia, but one of them is iron deficiency anemia, probably the most common of them, and this occurs when you don't have enough iron to make these heme groups. So if you're iron deficient, you can't make enough heme, which means you can't make enough hemoglobin, which means you can't carry enough oxygen. So the simple solution in that case is consume more iron. And the easiest way to do that is to eat red meat. That's personally my favorite way to acquire iron. I wouldn't recommend iron pills because it's very easy to overdose on iron, and the symptoms are not always incredibly obvious that iron is the problem. So if you do iron supplements, just be careful with that. Obviously, red meat would be a good source because it has a fair amount of blood in it. So basically, the blood in the muscle is what you're directly consuming and using for your own blood parts. If that's not an option for your particular dietary practice, then you might look at something like dark green kale and spinach and that sort of thing are going to be relatively high in iron, and so you can get iron in a plant form. It's just, in my opinion, not quite as fun as eating a nice juicy steak or a hamburger or something like that. If we look at where red blood cells come from, we want to look at this hematopoietic stem cell, this hemocytoblast. This is what all formed elements come from. So you notice it goes through a number of different developmental stages and eventually becomes the erythrocyte. If that cell took a slightly different direction of development, and we'll see this in a minute, it would become a white blood cell. If it took a different stage of development in this process, other than becoming a red blood cell or a white blood cell, it would become a cell which breaks into pieces and becomes platelets. So all blood cells, red blood cells, white blood cells, and platelets, which are basically just cell fragments, all come from these hemocytoblast cells and just differ in their development after that point. So it's a fairly complicated process that we have here getting to a red blood cell. The number of red blood cells present in your blood and in circulation at any given time will vary greatly from one person to the next, and perhaps from one even month to the next or week to the next, depending on your individual experience. So let's say that right now you have an appropriate number of red blood cells to be able to do what you do. So some of you perhaps can run a mile, and you could do so comfortably, and at the end of running that mile still feel okay. For me, I'm not sure I could survive running a mile, but one of the key differences between me and those of you that could do that, besides the fact that you're probably much skinnier than I am, is the number of red blood cells you would have in circulation. So physical activity determines the amount of oxygen that you need. Then your body tries to adjust the red blood cell count to accommodate that. So if you're used to doing what you do right now, and then you experience an hypoxia event, and this is probably not just a out of breath for a few seconds because you were about to miss your ride to the grocery store or something like that, but more of a long-term oxygen deficiency, the kidney then becomes oxygen deprived. When the kidney is oxygen deprived, it releases a hormone called erythropoietin, or EPO, and that erythropoietin goes to the bone marrow, the red bone marrow, and it stimulates it to make more red blood cells. So increasing levels of erythropoietin stimulate increased rate of red blood cell production. Once the red blood cell count increases to the point where the kidneys are properly oxygenated on a regular basis, then they will stop releasing, or at least cut back on releasing erythropoietin, and that will then slow down red blood cell production in the bones. So this is a constant adjustment and feedback. EPO goes up, EPO goes down, red blood cell production goes up or down accordingly, and typically your body keeps it where it needs to be. So for me to get to where I could run a mile and not risk death in the process, I would have to start out slowly with smaller amounts of activity. The kidneys would say, okay, we have this demand that's being placed on oxygen capacity. We're not getting the oxygen that we need, so let's release erythropoietin, make more red blood cells, and those red blood cells would then supply the demand. So increasing physical performance is to some degree an exercise in increasing red blood cell production. Over the course of a month or so, I would be able to, if I really wanted to, stimulate my body to make enough red blood cells that I would be physically capable of running a mile and still be roughly able to breathe at the end of it. The same sort of idea occurs with differing elevations. So around here we have the elevation we have, and with that comes a certain atmospheric pressure. Now atmospheric pressure really determines oxygen availability. The higher the atmospheric pressure, the higher the oxygen content of the air. The lower the atmospheric pressure, the lower the oxygen content of the air. So around here your body is calibrated to the oxygen content that's available. And let's say you go to Denver. In Denver, Colorado, you'll discover that the elevation is much, much higher than it is here, which means atmospheric pressure is down, oxygen concentration is down. So the number of red blood cells you had here in Kentucky and Tennessee that was appropriately calibrated for here is no longer sufficient. So now your body reacts by erythropoietin, more red blood cells, and within about a week, you'll notice that you can do things again there without being out of breath and gasping for air, because now you have more red blood cells that are capable of capturing that smaller amount of oxygen that's present. So the less oxygen there is, the more red blood cells you need to be able to capture enough of it to function. Let's say you get to the point where you can run a mile comfortably in Denver, then you come back to western Kentucky or Tennessee, and now you'll discover you can run a mile and a half, maybe 2 miles, and feel the same way that you would have felt running a mile originally. Because temporarily you have a supercharged number of red blood cells in the system, meaning you have a supercharged oxygen carrying capacity, and temporarily gives you enhanced physical performance abilities. Now, your kidneys will then decide that they have more oxygen than they need. They'll release less erythropoietin, which means that red blood cell production will slow down. Because these red blood cells are dying at the rate of perhaps 100 million a day or more, then relatively quickly the number of red blood cells will go down until it gets to the level that you need around here. So that would be a fairly temporary form of performance enhancement, just by stimulating more red blood cell production, and enjoy it while it lasts. Some of the modern approaches to that are things like you might see people wearing a breathing mask, and not because of worry about a virus, but the mask is to restrict their ability to breathe. So they're somewhat forcing themselves into a hypoxic condition. They're forcing their body to become oxygen deprived, and that then triggers this red blood cell production, which sort of, I guess in a way, supercharges your workout. So it gets you not only the cardio, but it gets you a far more than you would otherwise be able to achieve number of red blood cells. I have a couple of problems with that, and one is, why would we deliberately, chronically deprive our body of oxygen? If the kidneys are short on oxygen, that means the brain is too. And the brain really doesn't work so well and very quickly dies if it's oxygen deprived. So that's one problem. Another problem is if you get too many red blood cells in circulation, the blood becomes less liquid and more of a gooey sludge, which means that it doesn't circulate well. You then have circulatory failure, and you can actually die because your blood clumps up in the blood vessels for no reason other than it's just so thick, and then you die of oxygen deprivation to essential parts of the body. So this idea is called blood doping, and that can be achieved by these breathing mask techniques. It can be achieved by injection of erythropoietin into the system. It can be achieved by removing your blood, filtering out the red blood cells and storing them in the refrigerator, and then after a week or so of your body recovering, then put those refrigerated cells back into the system is also another approach. But either of those approaches really, again, causes extra thick blood and then causes problem with circulation and oxygen supply. So I don't recommend those. And in the world of cycling, professional cycling, this is where this really kind of seemed to come from, because a lot of those cycling races are done in the mountains, so they would need that increased oxygen carrying capacity. But what they then found is that they would die in the middle of the race because their blood was so thick that it just failed to pump like it should. So be happy with a reasonable amount of red blood cell supply. Moderate, reasonable exercise is fine, but don't get too carried away with this process. Here we see the overall process again. Kidneys, erythropoietin, red blood cells go into circulation, function for 120 days or so, then die, and the whole process starts over again. When red blood cells die, they are sent to the liver and spleen, and what happens is they are recycled. The iron, as much as is possible, is removed, and other materials, other molecules are removed from those dead red blood cells, and as much as the body is able to, used to build new ones, so that you don't lose that much iron every day. So you don't have to replace all of your body's iron content every couple months. But some of that iron is lost into the system and can't be recovered and put back into more red blood cells. And in that case, it goes, and along with the rest of the leftover ingredients, go to the intestines. And in the intestines, it goes through some processes. You can see here, bilirubin goes to the intestine. It's broken down and processed into stercobilin, and then will eventually be excreted. But the point here is, much of the color, so the brownish color of fecal material, actually comes from red blood cell components, including some degree of iron, that were not able to be put back into new red blood cells and are excreted into the intestines as waste. So the coloration of the fecal material, to some degree at least, comes from dead red blood cell components coming from the liver. because that iron, some of it at least, is lost and not recyclable, you do need to have a reasonable amount of iron in your diet. And we've already mentioned that, but if you have a red meat kind of thing or a dark green leafy vegetable kind of thing in your diet on a regular basis, you're probably going to be okay. If you're worried about running short on something like that, you could take an adult multivitamin. And adult multivitamins, especially female multivitamins, will contain some iron, and that will help to replace what you might lose. And typically in females, you would see a higher iron content in a female multivitamin, and in general, a higher iron requirement in a female because of the monthly menstrual cycle, which loses whole blood. So that's normal, healthy red blood cells being lost with no opportunity for recycling at all. So that amount of iron lost every month means that females need to take in a little bit more iron in their diet. Again, we're not talking about handfuls extra, because if you get too much, it is quite toxic. But you do need to have a little bit more. One really common problem with red blood cells, and you'll have read in your reading assignment about the different flavors of anemia, and one of them here is called sickle cell anemia. And that's actually been renamed recently to be called sickle cell disease, because it's more than just an oxygen-carrying problem. So anemia really means that you don't have adequate oxygen-carrying capacity in your blood. If it's the iron deficiency anemia, it's because you couldn't make enough hemoglobin. If it's this sickle cell anemia, it's because there's a mistake in the instructions or in the genetic code for how to make hemoglobin. On the left here you see a normal red blood cell, and in place number 6 is a glutamate. On the right you see a sickled red blood cell, and in position number 6 is not a glutamate like it's supposed to be, but a valine instead. And that one single mistake in that 146 pair protein sequence causes the shape to go from normal round shape to the half moon shape. So it's a small mistake, relatively speaking. You got one incorrect ingredient in the wrong place, but the effects are significant. And not just in changing the shape, that also means that circulation is affected negatively, because these cells don't slide through capillaries nicely. They are more prone to clumping and spontaneous blood clot formation for no reason. They like to clump up in areas like the joints. So folks with sickle cell often have a lot of joint pain because of this blood sort of gelling up in those inopportune locations. There's also the anemia part, the decreased oxygen capacity on this deformed cell, so it can't carry nearly as much oxygen as it normally would, so that leaves that person short of breath. We also look at things like premature organ failure, so kidneys, liver, that sort of thing would fail much earlier in the process if you had sickle cell disease. And so without modern health care and treatment, we might be looking at a 40% or more reduction in life expectancy. So 40% is a pretty good chunk of change. With modern health care, we can greatly improve that, but we're still looking at perhaps a 10 to maybe 15% reduction in life expectancy. So a lot better than 40%, but it still is a significant negative factor in the affected individual's health. Most cases of sickle cell disease are restricted to the African American population, and that is because it seems that this particular mutation originated in Africa. And so you might ask yourself, why would something that is so problematic stick around for so long and become so common? And the numbers are somewhere around 1 in 400 African Americans in the United States have full-blown sickle cell disease, and many, many more of them are carriers. Remember the genetics idea of a carrier, and so many of them are heterozygous, having minimal effects, but still certainly being able to pass it on to the next generation. So why is it so common? And if we were to go to Africa, we'd probably find not 1 in 400, but maybe more like 1 in 4 or 5. And the reason why it's such a huge, prevalent thing is because there's actually an advantage to having sickle cell disease. And you might ask yourself, why would you consider having this problem an advantage? And the answer is, well, sickle cell disease kills you, let's say, in Africa with poor health care, maybe around the age of 40, 45, 50, somewhere in that ballpark. But malaria wants to kill you when you're 5. And if you have sickle cell disease, you are immune to malaria. And if you're a carrier, so you're heterozygous, that means that you aren't necessarily fully immune, but you have some resistance. And because malaria likes to kill young children especially, your choice is die when you're 45 of sickle cell disease, or die when you're 5 of malaria. So having this problem in Africa actually becomes a survival advantage. Here in the United States, clearly we don't have malaria, no advantage to having it whatsoever, but it is so deeply programmed into the genetic code, and it is capable, again, of being in a carrier situation, so it doesn't have to affect every person who possesses the gene, then it can persist in the population. Also, it doesn't kill you fast enough. And that might not sound like that nice of a thing to think about, but a lot of these kinds of problems can be self-curing or eliminating themselves from the population if they kill the person before they have a chance to reproduce and pass on that gene. Because sickle cell disease doesn't kill you until 40s or perhaps 50s, then that person has had plenty of time to reproduce, pass on those less than perfect genes, and so the next generation has it before the previous generation actually dies from it. So if it killed faster, then perhaps it would delete itself from the population. Probably biologically, that would be the preferable outcome, is for it to kill fast and then delete itself from the population so no one would have it anymore. But because it evolved so closely along with malaria, it's probably, no matter what we would do, probably never going to go away. So that's red blood cells. Again, most of the formed elements are the red blood cells. But we also have white blood cells. And here we can look at what we call the differential white blood count or the total white blood count. And that's going to include all 5 kinds of white blood cells in that count. And we want that total count to be between 4,800 and 11,000 cells per microliter of blood. So this is a very small amount of blood, and what seems to be, let's say, between 5 and 11,000 white blood cells per that tiny amount. So it sounds like there's a lot of them there. But relative to red blood cells, it's like they're almost not there at all. But we want that count to be within that range. If that count goes below that range, that suggests you have an inadequate immune system function. So your body's not making enough white blood cells to properly protect you from problems. If the count goes above that, that means you have a problem. And either that problem is an acute infection of some sort that your body is very actively dealing with trying to knock off, or it may indicate something like leukemia. And we'll talk about leukemia a little bit later here, and that was in your reading assignment too, I believe. Certainly not anybody's idea of a good time, but so within these numbers here, you're okay. Below or above them, that indicates probably some sort of problem there. So we can look at the 5 different kinds here coming up. And the first 3 are called granulocytes. The second 2 are agranulocytes, and that has to do with how granular are the structures of the nucleus. And to some degree, you can look at a picture and appreciate that. So if we look at the granulocytes here, the neutrophils, eosinophils, and basophils, they have a very obvious granular structure. Really rough, coarse, grainy-looking nucleus there. And so that's what classifies them as granulocytes. The agranulocytes will have that stuff too, but it's a lot smaller, and so you really wouldn't notice it as significantly. But if you look at the arrangement of the material within the nucleus of the cell, that gives you the ability to identify. So you can just look at these with some practice and identify, is this a neutrophil, is it a basophil, is it a monocyte? And that kind of thing is really useful because each one of these 5 types of white blood cells is specialized for a particular class of problems. If you look and there's lots of one particular type present, that probably would be very useful from a diagnostic perspective in determining what is the primary problem. Is it viral? Is it bacterial? Is it parasitic worms? Is it perhaps a allergic reaction or some sort of inflammatory response? Each of those things would have their own type of white blood cell, very prevalent for that kind of response. So let's look at these specifically. Neutrophils. Neutrophils are the most common white blood cell in circulation, comprising anywhere between 50 and 70% of the total white blood cell count. Neutrophils are relatively large in size. They're about twice the size of a red blood cell. So looking at this picture here, we can see this nice fat cell here, and looking at the red blood cells next to it, it's easily twice their size, or perhaps even more. Neutrophils are going to be attracted to inflammation. So anywhere you have an inflammatory response, and we'll get to that with the immune system later on, but an inflammatory response is a normal part of your immune system response. So neutrophils are attracted to inflammation. They are going to specialize mostly in bacteria. They can do a little bit of fungal cleanup, but mostly bacteria is what a neutrophil is going to focus on. And it does its job containing mostly in a process called respiratory bursts. And what they do is they engage in a really high rate of metabolism for a short period of time, and that metabolism produces bleach and it produces hydrogen peroxide. So your body actually makes bleach and it makes hydrogen peroxide inside your body. And what it does is it uses those chemicals to then expose this pathogen to, and those chemicals, just like they do to any other cell they come in contact with, will poke holes in it, will help to destroy and kill it in that process. So small amounts of bleach and peroxide in your body is a good thing, but don't put it in yourself. Let the neutrophils make it for you. Eosinophils next on the list, and these sort of look like a little alien face there. These are only somewhere between 2 and 4% normally of the total white blood cell count, so not nearly as prevalent as the neutrophils. They're about the same size as the neutrophils, and we can see that relative to the red blood cells. And the primary response of eosinophils is to deal with parasitic worms. So if you have a parasitic worm problem, perhaps you have eaten too much raw sushi or something like that, you may have picked up some sort of parasitic worm. And I'm specifically mentioning raw sushi because seafood, aquatic life in general, is often plagued with parasitic worms. It not only affects let's say the fish, but when you ingest the fish and it's not been properly cooked, then that worm can crawl around inside you and do the same thing inside you it was doing inside the fish. So certainly it wouldn't have to be fish. It can also come from undercooked meat of any sort. So always fully cook your meat before you eat it, and that will help to kill any pathogen parasitic worms that might be there. So high eosinophil counts, you might have a parasitic worm problem. We should also mention in fairness here that eosinophils also seem to be associated with allergies and with asthma. So if you're having allergy problems or asthma problems, you may also see a little bit of an eosinophil spike there. Basophils are the least common of the white blood cells, typically under 1% of the total white blood cell population. Basophils are involved primarily in the inflammatory response. And what they do is they release histamine. Histamine is an inflammatory thing that causes dilation of blood vessels. That also causes more fluid to accumulate in tissues. So if you have inflammation, swelling, that sort of thing, that is a result of these white blood cells. When you have inflammation that you're trying to cancel out, you take an antihistamine. And basically that suppresses the histamine release of these basophils and very quickly will cancel out a lot of that inflammation. But again, it is a normal part of your immune system response, so as long as it's not causing significant impairment of mobility or function, probably should leave the inflammation alone and let it do its job. If you can remember in Anatomy 1, we would have talked about tissue repair in Chapter 4, and we would have said that inflammation is there to isolate the problem, to keep it a localized infection rather than allow it to become systemic. So if you turn off the inflammatory response too much in those infection responses, you might actually allow them to become more of a body-wide infection than they otherwise might have been. Lymphocytes are the smaller, really probably the smallest of the white blood cells, and you can see here that they're roughly the same size as the red blood cells. So up to this point, everything's been about twice the size of a red blood cell, but now we're about the same size. In the world of lymphocytes, there are a couple of different flavors, and perhaps you've heard of these before: T lymphocytes and B lymphocytes, or T cells and B cells. And that's really important in the immune response to things like something you've learned before, so part of the acquired immune response. Lymphocytes are specialists in looking at virus problems. So if you want to know, is my sore throat a bacterial sore throat or a viral sore throat, that's quite useful because you know a bacterial sore throat could be treated with antibiotics, a viral sore throat cannot. So what the doctor could do is look and see, are there lots and lots of neutrophils relative to what there normally would be, or are there lots and lots of lymphocytes compared to what they normally would be? And whichever one is in higher numbers probably would tell you whether it's a viral or bacterial problem. T lymphocytes are also going to be involved in dealing with tumors as well. So sometimes your body can actually kill cancer on its own, perhaps even before you would know that you had cancer, and the T lymphocytes would be doing that as well. The B lymphocytes are going to be involved in plasma cells, and plasma cells produce antibodies. And we'll talk about antibodies in a later discussion, but it's a really important part, again, of your acquired immune system. You see a problem, especially when it's a viral problem, and you develop this response. And part of that response is go out there and actively attack the virus and the virally infected cells, and another part of it is to remember the problem, remember the solution, so if you see the problem again, it very quickly deals with it. That means that most folks only have the chickenpox once. We probably only have mono once. We probably only have coronavirus once. And that's a relatively new statement out there, but what they're saying right now is it looks like everyone who has coronavirus, even if you're asymptomatic, so even if you had it and didn't know it because you never had a sniffly nose, you never had a fever, you never had a cough, even those people are showing good antibody response numbers. And what that means is your body is seeing the virus, it is appropriately responding to it, and it is developing a memory. So that probably means, you can't quote me on this because I'm not a medical doctor, but the best of our information right now is suggesting that if you have coronavirus one time, you probably will never suffer from it again. So it looks like right now people are developing good immunity to it after having had it, and that's because of these lymphocytes responding to the problem, dealing with it, but also learning and developing that memory along the way. Lymphocyte numbers might be up to 25% of the total white blood cell count, or it could be more depending on, obviously, if you have a viral problem, it would be a higher percentage. If you don't have a viral problem right now, it might be a little bit lower, more towards the 25% range. Our last white blood cell here are the monocytes. These go back up to a pretty large cell again, and are going to account for somewhere between 3 and 8% of the total white blood cells. Now, these are probably going to be the biggest of the white blood cells, and if we look here, we're looking at 2.5, maybe 3 times the size of some of those red blood cells present. So really big cells here, relatively speaking. And these are going to be macrophages. And what that means is they go and they eat whatever pathogen or whatever foreign particle you might run across. So if there are certain bacterial problems, certain viral problems, certain especially chronic things like tuberculosis is a prime example of that, you might see higher numbers of monocytes present, and they're actively out there swallowing up the problem, eating the problem. And then once it's eaten, it's contained, it's destroyed, it's disposed of. If we compare red blood cells to the white blood cells, we see that in table 17.2 here, we've got descriptions of their shape. We've got how many of them there are. So we're looking at 4 to 6 million red blood cells per microliter and only our 5 to 11,000 white blood cells. So 5 million red blood cells for every 5,000 white blood cells. That's a pretty significant differential there. Then it tells us how long it takes to develop them or make them. So 15 days for a red blood cell, and they live 100 to 120 days. So this table is kind of nice to tell you about relative numbers, how long it takes to make them, how long they live and can do their job, and a reminder over here on the side of their function. So make sure you take a look at that and refresh your memory on these. There's the other part here. And here we introduce the idea of platelets as well. And we'll get to platelets specifically here in a moment. But their production time is shorter, but also their lifespan is significantly shorter as well. So interesting numbers there. Take a look. White blood cells are made in a similar process to what the red blood cells were made as. We're going to start up here at the top with that same hemocytoblast cell, and it's going to differentiate itself a little bit differently so that by the end, instead of making red blood cells, we made our 5 white blood cell types here. So again, the same original starting cell, it just takes a different turn in the path to maturity. If we look at platelets, again, the same starting stem cell, it just grows really big, then breaks into many, many fragments. And again, those fragments are used for blood clotting, to stop blood loss. So since we're talking about blood and blood loss, let's take a look at that. Let's say you cut your finger and you immediately have a drop in blood pressure at that site because the blood is leaking out rather than being contained. Then you have a vasospasm, which causes a vasoconstriction. So the blood vessel tightens up a little bit. That helps to partially close this damaged area. And then we have what's called platelet plug formation. So these platelets are always floating around the blood, and when they come to an area where it is damaged and where there's a little bit of this chemical stimulus present, they start accumulating there, and they start sticking to damaged tissue. And anywhere they find damaged tissue, they stick. They then engage in a positive feedback mechanism, meaning when one platelet sticks, it sends a chemical stimulus calling for more. When those stick, they send more stimulus calling for more. So you get a domino effect here, a snowballing effect, that the more platelets you get involved, the more platelets get called for. And usually in the matter of a couple of minutes, the platelet plug forms. So let's say you cut your finger now, and probably within about 5 minutes, it will have stopped bleeding on its own. And that was this formation of the platelet plug. Once there's no exposed, damaged tissue left, the platelets will slowly stop accumulating there, and the stimulus that was calling for more will go away. But the thought is it's better to overclot than it is to underclot and keep bleeding. So overreact in this case isn't an all bad thing, as long as you overreact with moderation. So that's a quick formation of a blood clot, and it's stopping bleeding. And then 3 is coagulation. And coagulation is when fibrin mesh occurs. And we'll jump up to the picture of that. Here's what a fibrin mesh looks like. And basically it's a protein web in which red blood cells get stuck, just like flies in a spider's web. This fibrin mesh forms over the top of the platelet plug. So the platelet plug was the quick and dirty seal. The fibrin mesh is the sturdy, long-lasting seal. And between those two, they're going to keep it closed until the blood vessel can repair itself, and then the body's going to start taking away that clotted material, removing it once it's not needed. And for an average cut or scrape, it might only take a couple of days to a week until that entire process, including skin regeneration, can occur. I've noticed as I age, my repair processes work more slowly, so it might take 2 or 3 weeks to heal a cut finger, whereas when I was younger, and not that many years younger, I've noticed a big change in the last couple of years. I used to be able to heal in 5 to 7 days, and now it takes 2 weeks. One of the many joys of getting older is nothing works as well as it once did. So this is the fibrin mesh. That's going to form a blood clot, a scab, if you will. Internally and externally is going to consist of this sort of material here. Now back to this image. This is a scary looking image, and I really don't want to beat your head on it. I just want you to appreciate that blood clot formation. Yes, it's the platelet plug. Yes, it's the fibrin mesh. But here are all the intermediate steps along the way. So what we're going to call most of these things you see here are called clotting factors. So these are chemical stimuli that trigger the platelets to show up, to trigger them to stick, to trigger the formation of the fibrin mesh. And so it's a very, very elaborate series of chemical reactions that results in platelet plug formation, fibrin mesh formation, and complete sealing of a damaged blood vessel. So just appreciate, lots of extra ingredients here required to make a simple thing like your finger to stop bleeding to actually happen. That means if you're short on some of these clotting factors, then you won't clot very well. You might bleed for a longer period of time. And you've probably heard of hemophilia. That's an extreme case of being deficient in some of these clotting factors. And a person with a standard cut finger might bleed for, instead of 5 minutes, might bleed for 5 hours. And something like a standard cut or scrape, instead of being inconvenient, might actually become life-threatening. So it's kind of a big deal in terms of the effects of being short. So here are those clotting factors listed out for you in a nice table form here. And again, it tells you its number, its name, what kind of protein it is. I don't so much care about those. But look at the source. Liver, 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 liver. Over and over we're seeing liver. So liver is incredibly important in the production of clotting factors. A handful of things that involve something other than liver, but for the most part, the liver is doing all of that clotting factor production stuff. You have a blood type, and perhaps you know what your blood type is. Perhaps you don't. But for those of you who do, it's going to fall in one of 4 categories. You'll either be A, B, AB, or O. And most of you probably are going to be type O. And as you can see by looking over here at the frequency within the U.S. population, in every ethnic group, type O blood is the most common. Every one. Some of the others might vary back and forth as to what's second most common or third most common within a particular group, but type O is the most common. And the difference between the different blood types has to do with the structures on the red blood cell and the antibodies floating around freely in the plasma. So the antigens on the red blood cell or the antibodies in the plasma, in the liquid part of the blood. So if we look at type A, if you're type A blood, you have type A antigens on the red blood cell and anti-B antibodies in the fluid. If type B blood is given to a person who is type A, the anti-B antibodies in the type A blood will cause the type B red blood cells to stick together. The anti-A antibodies in the type B blood will cause the A red blood cells to clump together. So the anti-A's in the B will make the A clump. The anti-B's in the A will make the B clump. And this might start sounding like Dr. Seuss, but just take a look at the picture. the shape of the anti-A's that you find in B stick to the A structures that you find in A. So A and B doesn't mix appropriately. If we look at type AB, it has both type A and type B antigen on the red blood cell, but it has no antibodies in the liquid. If we look at O, it has no antigens on the red blood cell, but both antibodies in the fluid. This then determines compatibility. So O is considered a universal donor. Anybody can get O blood if you have to. Now obviously if you're A and you can get A, that's better. But O will do the trick. The problem is if you introduce O to A, the anti-A in the O might cause some degree of A clumping. But it's going to be minimal. So you can survive that small amount of blood clumping. Same thing with B or with AB. So a little bit of clumping will be caused because both antis are present, but it's going to be minimal. You can live with that. The alternative being die without enough blood or live with a little bit of clumping. We're going to go with the live with a little bit of clumping. AB is a universal recipient. So you can get, obviously, AB blood. But if we look at the list there, every ethnic group has that as the least common blood type in it. So every group has O as the most common. Every group has AB as the least common. So if you're type AB blood, this is wonderful because you don't have to have AB blood. You can get A, you can get B, you can get O. Everybody else can only get O or themselves. So B can get B, it can get O, but it can't get A, it can't get AB. A can get A can get O, it can't get B, it can't get AB. So if you want to help people by donating blood, you want to be type O. So your blood is usable for anyone who needs it. If you want to easily receive blood, you want to be AB, because anyone's blood type will work. Here's the test to determine what kind of blood you have. And what they're going to do is they're going to add anti-A's to a drop of blood. They'll add anti-B's to a drop of blood and see which one gives clumping or agglutination. So AB, you see some clumping with anti-A, but you also see some clumping with anti-B. So that tells you if you clumped with both, you are type AB, because it has to do with what's on the red blood cell itself. But we said AB was a universal recipient. So again, there's going to be some clumping, but it's survivable. Type A, if you put anti-A, it clumps. If you put anti-B, it doesn't, because there was nothing for the anti-B to attach to. So if only anti-A clumps you, then you're type A. If only anti-B clumps, you're type B. If you get no significant clumping across the board from either one, you're type O. So this is the process the hospital uses to determine what blood type you are. Let's talk briefly about, and let's do it without a black screen, let's talk about restoring blood volume. What happens if you become deficient in blood? What can you do about that? And the simple answer is you can do a couple of things. One is you can get a whole blood transfusion. So they take a unit of blood and they're going to basically pump it into you. So that's restoring plasma. It's also restoring red blood cell count. If you just need a little bit of volume, but perhaps can survive without the red blood cell replacement for the moment, you might do a plasma transfusion. So in that case, or you could actually even do a saline infusion. So just increasing the supply of fluid in the body is perhaps the first choice. And if you need more red blood cell functionality, they can give you, again, the whole blood as well. If you may also get what's called a packed red blood cell transfusion. In that case, they've taken out most of the plasma and left it more of a concentrated red blood cell count. the book suggests that whole blood transfusions don't happen very much. I'm going to suggest that they actually do happen a lot more, but it's more of an emergency situation. If you're short on blood because you say you're severely anemic, okay, a packed red blood cell count or transfusion could be done. You aren't going to die in the next 20 minutes to an hour if you don't get that transfusion. But if you are going to perhaps die if you don't get blood really quickly, whole blood's going to be the way to go, because you not only need red blood cells for oxygen capacity, but you also need volume replaced at the same time. So if you're trying to fix a oxygen carrying problem, packed red blood cells may be the more effective. If you're trying to restore volume only, but you don't need more red blood cells, perhaps a plasma transfusion or saline will do the trick. If you need to restore both red blood cells and volume, whole blood transfusion probably the way you're going to go with that. There's also the Rh factor, which we talked about in the genetics a little bit, but the Rh factor is the positive or negative that goes along with your blood type. And this really has to do with mama and her compatibility with a baby. So if mama is Rh positive of something and baby's Rh negative of something, if the positives and negatives don't match between mama and baby, there might be an immune system reaction on mama's part to try to destroy what's labeled as a foreign invader of the baby. And if that occurs, that condition is known as hemolytic disease of the newborn. And if that baby's born alive, sometimes mama actually successfully kills the baby, but if the baby is born alive, it's probably born anemic. And you might need some blood transfusions and some other things to deal with that. The good news is that shouldn't be a big problem because we have the RhoGAM shot, which again convinces the mother that she has already responded with the immune system response. There's no need to respond again, and so that if mama does see baby's blood when she shouldn't, the immune system response is minimal and it causes a minimum problem to the baby. So RhoGAM shot, probably a wonderful development in medicine. Certainly a lot fewer babies dying at birth, right before birth, or shortly after birth, and probably has saved some mamas some health problems too. There's the idea of blood donation. So what's involved in donating blood? And that gets into American Red Cross standards and policies and procedures. And that's a big enough can of worms that I'm going to do a separate video for that. So watch the next video that's going to come out for you here is blood donation. And we'll basically go into the Red Cross's website and we'll go through all the stuff they say. Because some of the things in there, you wouldn't necessarily believe me without actually showing you that that's really what they said. So we'll take a couple of minutes in a separate video coming up here soon and take a look at that. And I'll throw out some potentially controversial ideas for you to consider, and then we'll have great fun with that. So hopefully you learned all there is to know about blood, and I'll see you next time.